Hello and welcome back to Talking Faces. I'm Dr. Raul Cheto and I'm joined, as always, by my co-host, Dr. Lee Walker.
Hi.
And we're lucky enough to be joined again by the amazing Dr. Toni Burke.
Thank you. Hello.
And you are joining us today from our studio in New York.
New York City, yeah. So
Yes.
good they named it twice.
Yes.
Yeah.
So today our topic is bang for your buck. So if you have that patient that we've all seen before that can only afford one syringe of product, what do we do with it? So I'm just going to open this up to the panel and ask you guys.
So we're talking about the 1 mil challenge.
Yes.
Yeah. Wow. Well, where'd you start, really? I think if it was for me, I would be suggesting to the patient that they may need to save some money before I'm going to intervene. But if I had to use...
You just send them away.
Yeah, I just send them away. I'm not getting involved in
away.
this challenge. No, if I had to, I think the area that I would treat on the patient would be the lips. And the reason being is because we have that thing which we've discussed before, gaze, but this is gaze to function. So when we look at each other, we look at eyes and mouth, but as soon as the mouth starts to move, then our focus then is drawn to the mouth. So this is what we call gaze to function. And if I'm trying to get the most bang for my buck with the filler, then I want to put the filler where it's going to get its most attention. So that's the reason why I would choose the lips.
Interesting one. Very interesting one, I have to say.
I always aim for, so let's say you have a patient coming through, it's the first time they've come to a clinic.
Okay.
And you have your little plan, you may have discussed with them, but they only have a limited budget. So, and it's actually, even if they did have a larger budget, I always go and start with the highest impact filler. And the reason for that is because I know then they'll gain some trust in me. You've treated, to some extent, hopefully, what was their main concern, and you hope they'll come back. So even if they need lots of other treatment or there's things you suggested, for me, it's whatever will have the highest impact for that patient so that you've gained them as hopefully a return client.
That's true. But one thing that actually no one's taken into consideration, to have a proper 1 mil challenge, I think we need to have real cases, real patients in front of us. Because it really depends on the patient. Because if you are treating an aging patient, so you're treating someone in their 60s, really, Lee, the lips? I would say, you know, if we look at evidence and we look at latest evidence from Professor Kotofan and his group from last year in June, if we look at the surface volume coefficient, if you're treating the aging phase, the evidence suggests that placing the product into the SOOF, the suborbicularis oculi fat, will have almost a 1-to-1 relation in terms of how much superficial volume it would express. So if I had 1 mil and I'm treating anyone throughout the aging process, I would do that. Pop it into the SOOF.
But what we have to consider here is that's just what we believe may be best for the patient. But are you also looking at how happy that patient is when they walk out the door?
Oh, they'll be happy.
I think if I, in my defense, if I could go back to the lips, I think what you're just concentrating on in your perception of the lips is the red lip. On the aging patient, you've got to look at the cutaneous white lip. And what's the number one thing that the patients are going to come in for? It's those barcode lines.
Yeah.
And if I've got 1 cc, then I'm gonna go for the cutaneous lip on the older patient. And if there's any left over, which there always is, I'm going to lift the commissures of the mouth. So I haven't touched the lips in a sense. I'm going to change. I'm going to swivel this round. I'm going to go for the perioral complex rather than the lips.
Now
Okay.
you get a whole area
Walker,
with your 1 mil.
Walker,
Okay,
I'm
but-
taking you down,
Yeah.
Walker. No. Okay. So you said perioral, right? So
Yeah.
we're treating not you said lips initially, now you say perioral. Can you realistically treat the perioral complex with 1 syringe of product?
Absolutely. Yeah.
In a 60-year-old.
Lee, I've seen you treat you like we used combinations of treatments, but like really?
I've got 1 cc, and if I choose the brand which I've got, I know that the rheology and the layers of the anatomy will allow me to place my own little layer of subcutaneous fat. Then I can go into the rhytids, and then I can lift the commissure, and I can do that. If I choose that, I can do that. And I will prove this to you.
You
okay?
heard it here,
You
guys. You
first.
heard it here.
I want to see him
1
place it
mil
in the
challenge.
suit.
Next time you see Dr. Walker, you ask him, can you treat this patient with just 1 syringe? And let's see what happens.
Well, it's called a 1 mil challenge for a reason, and we've got 1 mil. So I'd love to see your results of treating the SOOF on an aging patient.
I think Lee has a good point, because you will get patients coming in and they will say, I don't like this line. But you will never get a patient coming in and saying, I feel really flat right here.
No, but they always come with symptoms around that area, whether it's a nasolabial fold, thickening of the nasolabial fat, infraorbital hollowing, flat mid-face, lack of lateral
projection. But the 1 mil isn't going to fix it.
Oh, it will definitely help significantly. Tear trough under eye area, indirect results, the most bang for your buck, evidence-based.
I think viewers, I think that's what he's gone for. He's pinning himself on an evidence base, and these surface volume coefficients may or may be right. We have to go with those. But the challenge is where are we going to use this 1 cc to have the most impact? You're not particularly drawn to some of these anterior mid-face, are you? Because I don't think you've ever gone up to someone and say, oh, haven't you got an amazing anterior projection onto it? Haven't you got nice lips, or haven't you got nice teeth? You're drawn to that perioral environment.
Well, the thing is that number 1 is the eyes, then is the nose and the mouth. Now, the anterior cheek, the SOOF, will have an indirect impact on the eye. So I think that is definitely beneficial when you're treating the aging process. But going back to what Toni was saying earlier, I think that you do have to take into consideration your patient. What does your patient want? And if they can only afford 1 syringe, you have to choose something that's going to benefit them, but also you have to go with what they're asking you. Not correct?
Absolutely. I mean, and particularly when you're looking at sort of younger patients and they come through, and you might find that your 1 mil goes that little bit further, so you can add some to SOOF, you can add a little bit towards the chin and just give them that little lift in this triangle, which they may be happy enough with. So it completely depends on your patient and what is pointing out they desperately need at that time.
Absolutely. I think that's a very important thing, because when the patient comes, they're fixated. This line, I don't like this line. They're fixated to one particular thing. But it's our job to take a step back and actually assess and analyze the full face, so we can offer them a treatment that will be effective for them. But we also have to take into consideration what their initial complaint is.
Yeah, I agree.
Lee's not doing that. He's just going for the mouth.
I agree with all of that. But this is a very real world situation that we do find ourselves in clinical practice all the time. I only have this amount of money for this. What can you do? And they normally ask you what you would do, rather than you say, well, you look in the mirror, tell me, and they'll turn that back and go, but no, you're the expert, Toni. You tell me. You understand the face better than me. I don't think anybody understands the face better than the patient themselves, because they've been looking at it from day one. They can see the changes. They know what they're unhappy with. And one of the things that, for me, in my experience with it, is the number 1 requested treatment for patients coming through my clinic is the perioral environment and the lips. So that's the reason why I would choose that area.
I think it's a little bit different in London, and if a patient was saying, this is
in New York?
In New York, I think it's a little bit different in New York, and I think if a patient came in saying that they only had enough money for 1 syringe, so 1 mil, I'd be tempted to say, well, don't spend your money on a filler.
I did say that at the very beginning, but we have to. This is the challenge. We can't say no.
So you can't spend it on skincare.
I would actually approach this in a slightly different way, and I would have multiple 1 mil challenges with my patient. Sit down with them, list their complaints and how we will address them, and I will start with the highest impact treatment first.
So you're talking about progressive 1 mil challenge.
Yes, progressive, because also, Lee, you have to understand that, yes, I think when you're treating the aging process, you can have a really, really high impact treatment by treating the perioral complex. However, realistically, we have to treat the whole patient, and it's something that will take us more than 1 mil, depending on what area we're treating. And you're an expert and you're known for your lip technique. So yes, maybe you have a lot of 1 mil lip patients, but us people that treat normal patients here in New York and all over the world, Toni, I think we have different requests from our patients.
I'm going to reverse this question and say, okay, so you've only got 1 mil. Where would you not place the filler? Where do you think has the least impact on the face?
Deep medial cheek fat.
He's gone for the evidence base once again, folks.
There's one thing, you cannot argue with science. You can debate it as much as you like, but you can't argue with it. This is why.
I'd say on those heavy patients with jowling and you try to do the jaw,
Yeah.
again, if you're thinking about 1
Heavy
cc,
nasolabial fat.
then just put it somewhere else. And I think, Raul, you just said anywhere around the nasolabial fold, especially patients with a big area of hypertrophy in the nasolabial fat, stay away from it. It's not going to look like there's been any surface changes whatsoever. So I would avoid the jawline and the nasolabial fold.
I'd also include a tear trough in there. I find when you get patients in coming specifically for their tear trough, there's always something else going on that you might want to treat in preference. So I tend to not treat that as a first off one-time treatment.
Yeah.
It has to be a really specific patient, right? Because I think it's especially the younger patients that we were discussing in our previous episode, please watch it if you haven't, is the type of patient, especially male patients that are requesting, they're usually young, they're requesting treatments for the tear trough, and how we would treat the complex, right? Not just the area, so the anterior midface and also the tear trough. So a lot of these areas we're actually treating in combinations or we're treating them indirectly.
Adding on to Tony's question about where wouldn't you treat, you know those patients where you have had a very successful result and you've got some left over, and then you wave it in front of the face and go, there's this much left. Do you suddenly look at an area and go, I'm going to place it here? Or do you do what I call the clinical waste slam dunk, is you just go, in the result, I've achieved what the patients come here for, and I get, because the great temptation, isn't it? The temptation is huge to put this somewhere.
Well, I think it depends on what you're treating. And as you went back and you're treating the perioral area, you can nearly always use that whole syringe. It depends. So then if you're treating a nose, well, fair enough, you'll probably discard what you're not using. You know, you're not going to put 1 mil into a nose. So I think it's only in small circumstances are you not going to finish it.
Because
it's not usually a problem.
I think it's the curse of the last 0.2. That's where you're going to get
disaster.
That's the hematoma or the VO or something's going to happen. Or you've made an asymmetry with it.
Oh, let's just pop a little bit in your lips and boom, massive bruise. Oh,
so we have those tips that we do at the end of
I think you're
all
right.
So that little bit which is left over, don't show the patient, just throw it into the bin. With it, because I think the 1 mil challenge is a real thing, because I think people try to budget, and in all seriousness, what I try to do is I try to tell the patient that they're going to see almost a negligible result with 1 mil if we place it in certain areas. And I get them to buy into that philosophy of progressive rather than aggressive treatments. So we're going to see small changes.
That's exactly what I was saying.
Build up. No, but you're saying the progressive 1 mil challenge.
Oh,
okay. So it could be 2 mils on one session, 1 mil on another 3. So we're going to call it the progressive average 1 mil session then. Well, okay. So Raul always does this. You'll find out all the way through these podcasts. He'll suddenly change his mind when the landscape doesn't suit him.
What?
Okay.
That's you.
Mr. Evidence. Okay. So this 1 mil challenge is, it's brought up a lot of questions really, and it was brought to me by one of my delegates on my mentorship group, saying, what if you have those patients who just have enough money for one cc? And Toni, I think I heard you saying, well, I wouldn't use the money for the 1 cc, I'd use it for skincare.
Yeah, I would definitely consider it. This is if a patient can only afford that 1 mil and have no intention of particularly coming back in 2-3 months' time. I think for their quality of their skin from an aging perspective, I think they're better off going towards preventative treatments and towards skincare, which will last them at least at around 3 months.
So again, a lot of variables here because we're not discussing specific cases. So yeah, I completely agree with you, and I think for me, my sort of take-home message would be, do the treatment that will have the highest possible impact on your patient, I would say.
Yeah, I'd agree, but
whether
also...
it's skin, whether it's a CC, a product, whatever.
I mean, don't be afraid, like Toni said, to change your treatment modality. So move them away from fillers and suggest, I think this would be good, a skin peel would be great, or even toxin. Have you tried toxin? And again, I think we need to lead our patients, because for too long within aesthetic medicine, it's the tail that wags the dog, and the patient becomes really upset with the results. And you feel like you want to turn around to the patient and say, well, you asked me to do this. And then the patient says, yeah, but you're the expert. You should have told me another way. So I think it should be very clinician-based consultation, and say no when you need to say no, and say yes when you need to say yes.
And treatment planning, right? I mean, it's always easy because all our patients will have limited budgets. So planning a treatment and saying, okay, this is step 1, step 2, step 3, having it in writing, get your patient to sign it, give a copy to your patient. I think that's a really, really useful way of educating them and also retaining them possibly.
Yeah, I think it's a really good thing. Also, within that budget, I don't think we tend to discuss about the maintenance of the results.
Well, this is a good question. So a lot of patients now ask whether they have any sort of financial planning with their fillers. And so for these patients who can only afford 1 mil, or for financial planning throughout the year, what would you do? Do you offer it?
We have offered finance plans over the year, but I think it's one of these treatments where people always seem to find money for aesthetic treatments.
So you mean everyone actually can afford more than 1 mil?
For the lips, right?
Yeah.
I think
so.
5 mil later.
It's the want more than the need. It's those treatments which they want them. They don't need to have them. It's so they will find a way, and it's normally sort of, they will pay you under the cover of darkness with their husband don't know, and secret bank accounts. I'll use this card. This is my secret card. Nobody tends to know. I think there's always money, but I think financing it is a really good way, and managing the budget, and also sometimes holding the reins back on the patients who are trying to go a little bit too far and do have the money. It's reining those back in. Yeah. So I think we're going to finish, and we'd like to have Toni, our guest, to have the final word, as always. So, Toni, the 1 mil challenge, it's left a lot of questions behind. So
where,
Toni?
Where would you put it?
I think there was a little bit of agreement that where it has the highest impact for your patient. Would you agree with that?
So now we're back to just...
Well, this is what I said, and this is what you said, and then I think your patients actually like having their lips in your area, so it is the highest impact for them.
No,
always.
If you want to stick your
he
flag
won't
in the
even ask
ground,
you what treatment you want, just lips.
So you've just seen, and we'll end this now, you've seen 2 politicians answer the question, and you've seen someone really honest do it. So all of your comments should be directed to these 2, okay? So I've stuck my flag in the ground and said perioral. These 2 are a little bit fluffy.
You said lips, you started with lips, mate.
We're going to say perioral. And on that note, we'd like to say thank you very much to Toni Burke. Yeah.
Thank you for joining us again. Hope you enjoyed it. Please like this video if you like it, interact with us in the comments, and also subscribe to our channel. Thank you so much.
Take care. Bye-bye.
Bye-bye.